have people joining in today. If you haven't gotten a chance to check it out, you can look at the ACVNU's YouTube page, and we have a recording of our first round session up there. Similarly, this session will be recorded and it will get posted onto our YouTube page within the next day or two. So hope for everyone to have that opportunity to come back and to review these sessions, which are always very great. And we're excited today to have Dr. Joanna Finstead leading the discussion on molidustat. 2 papers today talking about the pharmacokinetics in healthy cats and cats with chronic kidney disease. So really looking forward to this. And we have some of the authors from the manuscripts that are here, at least one that I can see quickly. So that's always fun as well. And yeah, Joanna, I'll let you go ahead and take it away.
Perfect. So hi, everyone. Thank you for joining the ACVNU Journal Club today. And as was said, we're going to discuss the 2 journal articles about this kind of new to veterinary medicine class of drugs called hypoxia-inducible factor prolyl hydroxylase inhibitors, or as I will refer to them, HIF-PH inhibitors. So I'm not sure how familiar everybody is with these drugs. Obviously, we have some varying knowledge bases on this group today. So I'm going to start out with just a brief overall introduction to this class of drugs, how they work, and then we'll dive a bit more into the studies. And as always, please feel free to chime in, and there should be plenty of time for discussion at the end, which I am quite excited about. So without further ado, there we go. So this image is from a pathophysiology review, and it does a nice job of just kind of demonstrating the basic process of erythropoiesis. And as I'm sure everyone knows, erythropoietin, or EPO, is a really important glycoprotein in regulating erythropoiesis. And so EPO is made by special renal interstitial fibroblasts. And the delivery of oxygen to the kidney depends on the concentration of hemoglobin. And so when this concentration decreases, the pericytes sense the hypoxia and produce EPO. EPO then enters circulation through the bone marrow. It binds to the EPO receptor on specific erythrocyte progenitors, and it prevents them from undergoing apoptosis. Thus, they get released into circulation, and we have more red blood cells. So EPO is produced by the liver in utero, but the kidneys do the vast majority of the job after birth and in life. And so EPO production in the kidney is regulated at the mRNA level. And so then EPO transcription is usually increased under hypoxic stress and anemia, indicating that there is some sort of oxygen detecting mechanism in place to initiate this transcription process. So that kind of brings us a little bit, or we'll start the discussion into HIF. And so from that same pathophysiology review, we can appreciate that in a normal kidney, when hypoxia occurs, the pericytes produce EPO by the binding of this HIF complex to the EPO gene. This then leads to EPO transcription. Subsequently, increased erythrocytes in circulation leads to improvement of tissue oxygenation and therefore a decrease in EPO production. And the way that that negative feedback happens is by degradation of that HIF complex by the HIF-PH enzymes. So now in CKD, there are a few theories regarding the mechanism of anemia, but one of them is that these parasites transdifferentiate to myofibroblasts, which results in a massive extracellular matrix deposition and fibrosis. And so the EPO regulatory element in those myofibroblasts undergoes silencing, and it reduces the binding capacity of that HIF complex, or potentially increases its degradation, which thus results in a decrease in EPO transcription. Among the factors that are related to renal anemia, the most important one has shown to be EPO insufficiency. So kind of our current options for chronic kidney disease anemia in cats are erythropoietin stimulating agents. Obviously, darbepoetin, I think, is what most people are using, iron dextrin supplementation, and then potentially HIF-PH inhibitors. So medications or drugs that are going to prevent that degradation of that HIF complex. And so currently still, the standard treatment in both humans and cats is considered the ESAs and iron. But let's dive a little bit more into HIF and its many effects. So as I mentioned, hypoxia-inducible factor is a key transcription regulator of EPO production, but it also appears to have other additional effects which are related to EPO, but not all of them. So it also primes erythropoiesis through iron metabolism by causing iron to be released from internal stores and transported. And then absorbed and stored iron is released into the circulation via that FPN ferroportin, and then complexed with transferrin for transport to the liver, bone marrow, reticulocyte endothelial system, and other organs. In addition to EPO, hepcidin is thought to play a central role in the pathogenesis of anemia of inflammation and can be elevated in patients with chronic kidney disease, and in this I'm talking about humans, due to reduced renal clearance, the presence of uremic and the presence of uremic inflammation. So hepcidin impairs the iron release from stores by degrading that FPN. And so interestingly, hepcidin is decreased in the presence of EPO through upregulation of erythropoietin. And studies have shown that when HIF-PH enzyme inhibitors are used, we see less hepcidin, and so kind of less decrease or less prevention of iron being absorbed. So it kind of has these kind of downstream effects to prime the body to make more red blood cells. And then lastly, which is kind of could go either way, but FGF23, which is mainly produced in the osteocytes, regulates phosphate homeostasis. And so plasma levels of FGF23 are elevated in patients with CKD. And again, I'm talking about human patients. And it's an independently known risk factor for end-stage kidney disease and cardiovascular mortality. And HIF activation, as well as EPO and iron deficiency, can actually increase FGF23 mRNA transcription with increased post-transcriptional cleavage. So a little bit hard to kind of know where that is going to play. But what I'm going to kind of imagine is we'll kind of learn more as we're using these drugs more. And so long story short, the pharmacological activation of the HIF pathway or inhibition of the enzymes which degrade the HIF complex, and thus the subsequent increase in endogenous EPO production, constitutes a therapeutic target for treatment of anemia in CKD. There are tons and tons of papers on the human side that have looked at this a bit further and are showing that this is a pretty promising agent over using ESAs. And so let's now dive a little bit into the papers and this veterinary conditionally approved HIF-PH inhibitor, which is a molidustat called Varenzin. So our first paper is a pilot study which was funded by Elanco that looked at the HIF-PH inhibitor, otherwise known as Varenzin, in healthy cats. So this was a prospective, randomized, placebo-controlled, open-labeled laboratory study that had a population of 17 healthy cats between the age of 1 and 2. All of them were altered. And kind of the study goal was to give the drug for 56 days, and then weekly to monitor their hematocrit, have twice weekly physical exams, monitor kind of overall safety study, get an idea of the pharmacokinetics. And the groups, there were 3 different groups. One of them, the first group 1, is 6 cats, and that was considered the no molidustat or our placebo group. Group 2 was a 5 mg per kg dose once a day, and then group 3 was a 10 mg per kg dose Q24. And so the cats were given the drug, or everybody got a small amount of the same drug at the same time every day, and then every week had blood work drawn to kind of assess things. Before it started, there was a 2-week pre-treatment phase, which I'm going to call day -14 to day 0. And then a treatment phase, which again was day 0 aimed to be day 56. And that was the time in which everybody was receiving the drug or the placebo. And then the post-treatment phase, which was aimed to be day 56 to day 98. So that we're monitoring the cats well after the drug had stopped. And the rescue that was in place for any of the cats that were not receiving a placebo, I guess also if they were receiving a placebo, was if the hematocrit was greater than or equal to 60%, the drug would then be stopped for the safety and welfare of those cats. So as we get into the results, we start to see, I don't want to say where things went awry, but see how we did not get to day 56 of treatment. So here we can appreciate that the placebo are the triangles, the dotted line with the circle is our 5 mg per kg dose, and then the square is our 10 mg per kg dose. And so the biggest, what we're starting to notice is that on day 14, which is our purple arrow, 2 of the 5 cats in the group 3 group reached a 60% hematocrit, and so that drug was stopped. Because so many of those cats were affected, on day 15, the remainder of those cats in that group 3, so the remaining 3, had the molidustat stopped. So then on day 21, which is our teal error, our group 2, which is our 5 mg per kg dosed cats, 3 of those 6 cats reached 60% hematocrit. And so the drug was stopped in those 3 cats. And then 2 days later, which was day 23, the remaining 3 cats in the 5 mg per kg dose reached 60%, and so the drug was stopped. So the treatment time of 56 days ended up being a max of 23 days, depending on which group. And what they found, and you can see the stars there, is that in comparison to the placebo, there was a significant difference in hematocrit starting on day 14 and until the treatment period ended on day 23. And again, they continue to monitor the cats weekly, and we can see that the hematocrits kind of slowly dropped back down to normal and to kind of match the same as that placebo group. So they also looked at red blood cell count, hemoglobin, reticulocyte, and hemoglobin in reticulocytes over the study period. And so what we see with this, as I add the hematocrit numbers, is you can see those values all kind of match up together as the hematocrit went up. Everything that you would expect to happen with the red blood cell count, hemoglobin, and reticulocytes occurred additionally. Come on. There we go. So the other thing with this study that they were looking at was a little bit of pharmacokinetics. And so here we can see the molidustat plasma concentrations. And so you can appreciate that the mean molidustat concentration peaked at about 2 hours post-administration, with mean concentrations ranging from 1900 to 2200. In the higher, or the 5 mg per kg group, and then in the 10 mg per kg group, oops, said that wrong, but the concentrations, yeah, in the group 3, which is the 10 mg per kg, were kind of doubled that. So in a 3,900 to 4,500 area. And so again, but similarly, after 2 hours of concentration, we had that peak. And so then subsequently, the mean EPO concentration significantly differed in the molidustat treated groups. And so 6 hours after treatment compared to the placebo, you can see that peak EPO concentration in the plasma. So then in terms of adverse events, really the only adverse events that were appreciated, aside obviously from the hematocrit getting a bit high, was vomiting. And so vomiting was appreciated in all 3 groups. Again, not terribly surprising because we're talking about cats, but the incidence of vomiting in group 2 and 3, so the molidustat treated groups, did have more incidences of vomiting, and there was only 1 incidence of vomiting in the placebo group. It is important to note, though, that the vomiting was not witnessed, and so it was more that vomiting was found, and these cats were grouped together. So it's unknown if it was the same cat that was vomiting or kind of something else in between. So before we go into further discussion, unless anybody has some burning questions, I was going to go into the next study. So does anybody have any immediate thoughts, questions, comments? Perfect. I'm going to power through then, and we'll kind of go into the next study. So we've all gotten a little bit excited and intrigued about HIF-PH inhibitors. So let's see what happens in non-healthy or CKD treated cats. And so this study is a multi-center, randomized, double-masked, parallel placebo-controlled field study, and it was designed to investigate the effects and safety of molidustat as an oral suspension in client-owned cats in both the United States and Europe, in cats that were anemic associated with chronic kidney disease, when they were administered, again, this daily dose for 28 days. And so to be eligible for inclusion, the cats had to be over a year of age, a body weight greater than 2 kilograms, diagnosed with an anemia with a PCV less than 25% at the initial screening, and then additionally on day 0 of the treatment, and that anemia had to be associated with chronic kidney disease based on historical patient data, and then a serum creatinine concentration of greater than 1.8 mg per dl without any additional staging. So normal blood pressure in these cats. The cats were allowed to be receiving crystalloid fluids, sub-Q. They were allowed to have other comorbidities, but those comorbidities had to be stable for at least 2 weeks, or in the presence of hyperthyroidism, at least 6 months. And so that was obviously in an effort to make sure that it's just the kidneys causing this anemia. Cats were also excluded if they received previous treatment with erythropoiesis stimulating agents, or if they had a blood transfusion, or both. If they had severe clinical signs of inflammation that were not attributed to chronic kidney disease, and then other uncontrolled clinically relevant medical conditions, or if their FELUC or FIV status was positive, or if there was any evidence of GI bleeding. So there were a total of 15 cats that were treated at a 5 mg per kg dose for a total of 28 days, and a total of 6 cats that received a placebo for those 28 days. And similar to the previous study, blood samples were collected weekly in both of the groups. And so just some baseline characteristics of the study population showed that the groups were mostly domestic short hairs. They were mostly evenly matched in age and body weight, and in sex a little bit, although the control is a little bit swayed for whatever reason that ended up happening. And then nearly even, again, distributions. And so there were no comorbidities unrelated to the CKD in the control group. And then there were 3 cats with hyperthyroidism, 1 cat with coccidiosis, 1 cat with cystitis, and then 1 with suspected osteoarthritis in the molidustat treated group. And then several additional medications were used during this study to treat the clinical signs of CKD or any comorbidities at the discretion of the attending veterinarian. And that the information is available. So to get a little bit into the results, in general, the margin for treatment success was determined to have a hematocrit greater than 25% and or a 4% point increase in hematocrit from that initial baseline. And so for reference, I've drawn a yellow line here just to indicate the 25% hematocrit. And so what we can see here, the dashed line are our molidustat treated groups, and then the solid line is going to be the placebo. And so the mean hematocrit of the molidustat treated group increased weekly, and there was a significant increase that was compared to the baseline at day 21, and you can see the star there. And then at day 28, there wasn't as significant of a difference there, but it still was considered therapeutically efficacious at day 28 because we were above that 25%. And so again, compared to the control group, the mean hematocrit of the molidustat treated group was significantly higher. One thing that I do want to point out here, which we'll get into a little bit more, but is that even so at 28 days, our hematocrit, even in our treated group, is still, I would argue, not even close to 30. The mean was about 27%. So we're still not kind of in that dangerous 60% range that we saw in those healthy cats. So then the top table here shows the mean hematocrit and PCV in the molidustat treated group of the 15 cats. And again, important to notice that by day 28, the mean hematocrit was 27.8% and a mean PCV of 26.2%. So while it is above that 25% treatment success, it's still not even close to 30%, which I think we would all argue would be nice. And so overall, the number of individual treatment successes on day 28 was higher among the molidustat treated cats compared to the control cats, but there wasn't a significant difference between those groups. Other hematologic parameters, including red blood cell count and reticulocytes and hemoglobin, increased over time, but weren't statistically analyzed. And again, those tables look very similar to in the first study. And then that bottom table shows the percent of treatment success. And so at day 28, 50% qualified to have treatment success in the molidustat treated group, but that wasn't statistically significant. And so one of obviously the goals of this study too was to look at kind of adverse effects. And I think one of the more important things, which is not an adverse effect, but is that we didn't see any dangerous levels of hematocrit achieved in the disease affected groups. And then other kind of main adverse effects were vomiting, and that was 6 instances of vomiting. And so one cat could have multiple reports of it. And then 3 cats did die during the study. 2 were in the molidustat group and 1 were in the control. None of the deaths seemed to be, or all of those deaths, I should say, were related to complications of their kidney disease or other disease processes. It sounds like one of them had a thromboembolism or a suspected thromboembolism, so it didn't seem to be related necessarily to the drug. And then there was one cat that developed a hepatopathy, which with a pretty significant increase in ALT. So then the other, I think, cool thing that this study collected was some continuation data in the molidustat treated group. And so I think the most important things that I take out of this are, one, if you look further out, we're noticing that there is an increase in body weight over kind of the course of 28 days to 84 days, which I think everybody can appreciate that a kidney cat that's a chronic kidney cat that's gaining weight is an amazing good thing. Could just be medical management, but it's always nice to see. And then that there's a continued increase in the mean PCV after the 28 days. But again, even out to day 84, they're still not even reaching 30. So we're still not getting into that scary range of a hematocrit. And then the last thing, which I love, is that there was minimal to no systemic hypertension that was appreciated. And we know that with our current ESA drugs, systemic hypertension can be a complication of it. So if we're kind of comparing those, that can be a pretty cool bonus that we see. So a little bit of a take home that I like looking at these 2 studies is that chronic kidney disease cats definitely do not act like healthy cats when given this drug. And so those healthy cats given the molidustat, their hematocrits leaped up pretty quickly into some pretty decent ranges, but our kidney cats really didn't. And I distorted this image a little bit just so that you can appreciate a little bit more that even the treated groups, while we're seeing it increase, it was never even getting above that 30% at that 5 mg per kg dose that they were administered. So something that I absolutely have to mention about this product is Varenzen is under conditional approval from the FDA for chronic kidney disease cats at a dose of 5 mg per kg orally once a day for 28 days. And then a 7-day pause or drug holiday is required every 28 days that the cats are on the drug. And so that pause is for that safety based on the healthy cat study and seeing those kind of rises in hematocrit. And we've started using this drug here at Ohio State, or at least I've started using it in some of my patients. And my very unofficial and anecdotal experience is that I'm not seeing a whole lot of side effects associated with it. I'm not seeing a change in the vomiting of my cats. But using it with that 5 mg per kg dose, I'm also seeing what I would consider to be a bit of a disappointing increase in PCV. Now, I will give full disclosure that I'm an extracorporeal fellow here, and so my patients are quite unwell and are at kind of varying degrees of end-stage acute kidney injury or end-stage chronic kidney disease. So at least that's my kind of anecdotal experience. But one of the reasons I wanted to do these studies and to talk about it is to kind of hear what other people's experiences are, hear what you're appreciating kind of with that 7-day pause. Are you seeing vomiting? Because this is, I think, a really cool, exciting new drug, and it's out on this conditional approval. And while we're waiting for more studies to tell us kind of where we'll be able to go from here, it would be just kind of interesting to hear from everyone. And so overall future directions, I think we have tons of them. So kind of specifying molidustat use in dialysis patients, or specifically AKI patients, use based on IRIS CKD stage, obviously more clinical trials and dosage trials, and then kind of the question of to iron supplement or not to iron supplement. And that is something that wasn't kind of really specified. So would love to hear a little bit more from everybody.
So Quentin made a comment in the chat that it seems well tolerated and it's been working better in CKD than in the AKI patients. So, and I do think that's true.
Yeah, I absolutely had to give full disclosure that when I'm talking about my anecdotal experience, my patients are rough. So I think in the more chronic patients, it definitely seems like it could be a little bit better.
And perhaps taking 50 mils of blood out of them every other day is having an impact, even though you give the blood back.
And interestingly, on the human side, they looked at both kind of using the HIF pH inhibitors in a non-dialysis and dialysis patients, and there definitely is a difference. But there's a handful of studies in both directions, but that show that it's not inferior to ESAs in dialysis patients.
Yeah, I would agree with you, Joanna. We've been not that excited about its results when we've used it to help manage the anemia in some of our AKI patients. And I've used it concurrently with darbepoetin in some cats that just needed cells every time you treated them. So with still minimal results, it would seem, but that is a patient population that is just going to be probably the most challenging to treat in terms of the loss that they have, combined with the probably significant inflammatory state that they have. But we've seen nothing that's really all that exciting with it. I'll probably still try because we don't have much to lose, but it hasn't seemed to work very effectively in our small number of patients with AKI that were getting dialysis that we treated. Our last patient with CKD, like Jessica mentioned, had actually responded pretty well in the 28 days. Went from maybe 23% as a starting hematocrit, and I think it was up to 38%. And I was pretty shocked, not expecting to see that based upon the second study. And so that has been my most successful response that I've seen. And then now we start the annoying phase, right? So now we have to stop it for a week, and then the cat has to come back in, and I have to check it again, and then maybe start again. And talking to a lot of vets, it seems like the enthusiasm for this dosing protocol is very scant. And because it's conditionally approved, we are all legally obligated to dose it this way. We can't go off label yet until if it ever receives full approval. So it is a very, very annoying drug to give. I don't actually enjoy asking my clients and the cats to have to come back in that much to get their blood checked and whatnot. So I do think that that's going to be a big hurdle to people adopting it for usage with the current dosing protocol. It is a big pain in the butt.
That's the nice thing about its use in the acute kidney injury cats is that they're here a lot.
Right. They might not make it to day 28, so you can just give it every day.
Yeah.
And the company does know about these dose and monitoring struggles. It seems like there's always a compromise when you're trying to get something through the FDA. And so that's not, to me, that's not the label that I would want, but hopefully when it does become fully approved, we'll be able to use it off label and maybe adjust the way that we're using it, not have that 1 week holiday, and adjust the monitoring protocol to something a little more rational for cats.
I think for me too, the other thing when we're allowed to make a little bit more adjustments is, seeing that 10 mg per kg dose, those cats jumped up faster, like would do these more severely affected cats or ones that we're not seeing as good of a response from just need a higher dose because their kidneys are so kind of shot and they're so incredibly EPO deficient that they need a little bit more help. And I think that's one thing that I wish I could do, and that I'm excited about kind of that opportunity to do that. Because again, the appeal, I think, is seeing the blood pressure really being okay in these cats is pretty neat for a lot of these CKD cats.
Yeah, and I suspect that the blood pressure is better because the drug is so slow to have an effect. When you look at figure 2, that day 21 is only significant because the placebo dropped, not because the drug actually helped.
Yeah.
And when you look at the extended continuation phase, I think there were 8 cats in that group, Kathy, and a number of them got it daily. Some got it, like the dosing was all over the place, but a number of them were still getting it 5 mg per kg once a day. And none of them went high. And I think to Jessica asked the question, has anyone seen a CKD cat develop, erythrocytosis on the drug? I certainly haven't. The data suggests that, at least here, that they don't. I don't know if anyone else has seen a cat with CKD actually develop erythrocytosis with this medication. I don't know if I maybe can think of one CKD cat that I got up into like the upper 50s with darbepoetin, but that's probably just 1 or 2. So it's still pretty rare for that. But I don't know if anyone has had experience pushing cats to go too high with the current protocol for molidustat.
If you'll permit me to sort of back up to the study of the cats that had CKD, and one of the charts showed a weight gain in the treated cats. And that prompted me to think of the fact that I was attending ASN meetings annually during the era when EPO first came to bear on kidney disease management in patients. And I'm not talking about any one study, but one of the things I went home with from meetings in that period is that the symptoms of uremia turn out to be symptoms of anemia. And one of the things that I think, and again, I'm not quoting any study, but my sense from that era is that patients felt better when they weren't so anemic, including ate better and consumed things that their dialysis prescription had to be changed in order to adapt to. And so it may not be that it has to be a PCV of 35 or 40 because that's normal to make enough of a difference in a cat who's running around at 22 to get to 28 or something like that, and feel enough better to feel better and actually eat enough to gain weight despite vomiting every now and then. The other thing looking at the data is that the placebo group, PCV actually dropped, I think it was 21 weeks, the third data point. And one wonders why, but of course, study animals are being subjected to vampire doctors. And so there's the bloodletting that goes with the monitoring, and that the treated group was still going up in there. So it's important, I think, to have the perspective that you don't have to make them like a normal cat in order to make them enough better to be worth the trouble of giving it to them.
Yeah, that's a really good point. And right, is that 27 that we're all kind of disappointed with, would that have been higher if they weren't getting bloodletted, as you said so frequently, is definitely a consideration. And yeah, I think we recently talked about in one of our journal clubs that we kind of underappreciate how crummy anemia makes you feel. We were actually just talking about that with the students too, that a lot of these patients probably just feel terrible. And is that enough of a difference to get them to gain weight? Yeah.
To me, I thought it was interesting that the clinically relevant increase, what was defined as success, I would say it's a rather conservative goal. A 4% increase absolute, or 25%, a 4% absolute increase in hematocrit, or 25% from baseline, is okay. But if you're starting at the hematocrit at 20 and now you're at 24, that would be considered clinical success here, which I would not argue that that patient is probably optimized, and I wouldn't expect them necessarily to feel less crummy at 24 than 20, but what do I know? I'm not a cat. But even with that very modest outcome to show success, it was only identified in 50% of cats that went through the trial that they had a successful outcome, not being statistically different than the number of success in the placebo. And certainly that was underpowered. As it goes on, the number of placebo cats get fewer and fewer as they likely died. So if you just look at this paper, I don't actually think that the drug shows itself to be that effective in the 28 days.
At that dose.
Yeah.
In the chronic
in CKD.
Yeah.
But if you look at the continuation phase graph,
Yeah.
You got up to maybe 75% of cats who ultimately responded. It just took more than 28 days for that to happen.
Yeah.
So, it does not look like it's going to fix every cat who has anemia of CKD, but 75% of them having a clinically significant improvement, I'll take it.
Yeah, I agree. And my point was in the study design, because the continuation phase is open label, completely uncontrolled. So you have some cats getting 5 mg per kg every day, some cats getting dosed once or twice a week, some cats getting 2.5 mg per kg once a day. So it's really hard to draw a lot of conclusions on how to dose them at that point. To me, I think it tells you that you can probably wiggle the dose around and probably come up with an effective dose, which makes sense. Like, that is, I think, how we'll eventually use the drug, is figure out the dosage and the frequency that is appropriate. But the 28-day dosing protocol of 5 mg per kg once a day, I actually think is fairly ineffective. If it's a 50% success rate, 40% of the cats vomiting with it, I think that's kind of a hard sell based upon that. Again, it's when we might have freedom to use it differently that I think we might be able to optimize outcomes. But yeah, I think the data from this is, if you ignore the continuation phases, is okay. I don't think it. If I only saw the initial data, I would not be very excited about this drug.
So what is the incidence of vomiting in CKD cats not on this drug?
There was only one incident. It was lower in the control group in the CKDs versus the molidustat treated group in the CKD cats.
Right.
But there
Okay,
definitely was more. Yeah.
Right. So 0% of the cats that got the placebo with CKD vomited versus 40% that got molidustat.
But I think what's hard too is like all these cats are on things, so it definitely can muddy the water. Like if who was on Serenia at the same time, yeah.
I struggle with the cats that have comorbidities too, especially like with chronic enteropathies. I've got a cat that did not respond initially to that 28-day course, ended up responding to the second 28-day course, went from a PCV of around 17% up to about 24%, but very much a delayed response. And how much of that is the chronic comorbidities that these cats are dealing with. I know that a large number of our cats do have some degree of, chronic enteropathies that are present, and it's not an uncommon, scenario that takes place. And so, how does that play a role with some of these responders and non-responders?
Yeah.
Did you give iron to that patient?
I did.
Okay.
And for what that's worth, we've been giving iron to all of our patients that we've been using molidustat in, just like we would with darbepoetin.
Because that's one of the things that was not controlled in the pilot study or the pivotal study. So they may or may not have received iron.
Right. And Kathy,
yeah, I would say that.
Go ahead.
Beddy.
No, go ahead. Go ahead.
Yeah, I would say that for most of our patients, we are essentially starting them in the same way we would start Darby, which is iron plus minus B12 if we've got a concern for an enteropathy. So we've kind of been using it the same way. I would say a reasonable proportion of our cats are post-sub, and it's kind of those ones that are kind of lingering. And again, we would use Darby in the same way of, how much is their CKD versus, inflammatory disease and post-surgical. Those patients have been responding pretty well. We haven't always had to continue the Varencin, as equally what we find with Darby, and said whether those cats, I think there's different factors involved with them, so it's, I guess, a little bit harder to assess, but so far those cats seem to respond well.
Yeah, that's what we were hoping to with some of ours, is like in subs or like a true AKI, is like if we start it, when we get to the 28-day holiday, do they need it anymore? And that has, well, that has not been the case, at least.
What would be really interesting is if they would have measured EPO levels on these cats like they did in the cats with that were normal, because the question is the 5 mg per kg, are you still getting that big spike in EPO, or are you not? Because maybe you do need to give more. Maybe you do get the same bump in EPO and it's the inflammatory conditions. Maybe it's the role of hepcidin and other inflammatory molecules that make that EPO less effective. But we don't know the answers to those questions right now. Kathy, I'm nitpicking a little bit, but the data presented in table 1, it's presented as if it's normally distributed. They're reporting mean and standard deviation. And I don't see in the statistical analysis that any normality testing was done. And it seems quite hard to me to have a normally distributed data set with 6 points. So can you comment on that data? I was a little disappointed that it wasn't actually tested for normality and the way that it's presented in table 1, I don't necessarily think mean and standard deviation is the best way to report a data set of 6 cats.
I'll have to admit, I don't remember those specific details. This is not the only study of this drug in cats with CKD. And I spent a lot more time evaluating the other study, the pivotal study, and then I evaluated this one, and then I've reevaluated the pivotal study. So I get really confused about which study is which because they're so similar. But obviously I don't remember any problems, because hopefully I would have pointed that out before we send it to before we submitted it. But one thing to point out is that in that control group on day 28, there's 1 cat. So there's no way that is at that point normally distributed. And I'd also point out that for the weight gain in the continuation phase, that the cats that were doing the worst had already dropped out of the study by then. So in a study that has 8 cats, it is very definitely a pilot study.
Right. Yeah, and it's interesting that at day 84, you have 8 cats that have blood pressures measured, but only 2 of those cats actually had body weights that were measured. So, like in figure 3, you have a box and whisker plot of 2 cats for a body weight, which is, probably again not a good representation of data, but it's going to be skewed, right? Skewed to those cats that are doing well enough to still be enrolled there. And I don't know, would have been nice if the other 6 cats could have had a weight at that visit too. But that's clinical trials, right?
Yeah, I was a bit surprised at how many data points were missing.
Yeah.
But it's also a study like, and for those of you who've been in multi-center studies, there would be 1 or 2 cats per center that was enrolled in the study. And despite that, it took all that time and all that money. It is not easy.
I still struggle what to do at altitude. This is something that we've definitely talked about in our group. And there's some variable data out there in people on hemodialysis receiving erythropoietin stimulating agents. And do we target a higher hemoglobin concentration? How does that all play a role? It's very much, I would say, a black box in a way. We just don't really have an idea. And so I just was curious if anybody had any thoughts or opinions there.
Well, hopefully Quimby will chime in on this. But when we were talking about the cats may feel better if their hematocrit's up to 28 or so, even though that's not normal. But certainly there is one paper that looked at progression in cats, and the cats, I think that the cats with a hematocrit of 36 or higher were less likely to progress than those below 36. And I may have that number, that cutoff a little bit off. But we would target for renal health to be a little higher. Closer to normal, at least.
Yeah, I guess that's a good question, right? Like, what are people using? Like, what's your clinical target? Ignore the guidelines or how it's written, but where's everyone trying to get their cats? We'll stick with cats up to for any type of, whether you're starting iron, whether you're using darbepoetin, whether you're still using Epogen, whether you're going to use molidustat. What's your target that you're hoping to get the cats up to?
Well, I used to have a target with Darby that with the cat, when it got to 25 to 30, I would back off on the dose But with molidustat, I would target 30 to 40. And Quimby is commenting median of 31% in the progression group versus 35% in the non-progression group in that study I was trying to mention.
I was going to say, in my head, I'm trying to target 30%, which I've yet to achieve. Gordon,
Go ahead, Jenna.
I was just wondering if, like, in the altitude, do you notice that patients are more intolerant of anemia?
You definitely see some patients come in, depends on how acute it is, but lactate levels in the 9s and things like that. I had a cat last week very similar to that. And so, yeah, I think that it does play a role. And like I said, there's some varying data out there in people that are on hemodialysis, and they start out with a higher hemoglobin concentration, and they seem to be with the erythropoietin stimulating agents, they seem to be more responsive. And whether that's a characteristic of being in altitude, it hasn't quite been determined, but it's kind of an interesting exercise to think about. And I think that's where I try to target 30. Is that right? Is that wrong? It's quite difficult to get there, though.
Yeah,
We
I
also
used
at
to
least
give it
have the
more
per-
conservative. Go ahead, Karina.
Yeah, I was going to say, we also definitely have the perception of maybe their patients being a little bit more prothrombotic at altitude. So there's that factor as well, particularly in considering Derby.
That's interesting.
One thing I will point out about the success rate of this drug, 50% at 28 days and up to, I don't know, 75, whatever, later on. In that retrospective that I wrote of Darby, only about 2/3 of the cat did I consider a responder, because a lot of those cats had so many comorbid conditions that they were, my opinion is that they had a lot of inflammatory things going on that were suppressing their EPO response. So while this drug may not be the best drug ever, compared to what we've got, it's still, I'm still using it. But I want it to be off of conditional approval.
Right, which could take
a year.
So, and what's interesting is that your paper on Darby, I mean, a lot of those cats were dialysis cats. So, going back to the initial comment that Joanna was making about the response in those patients that might be super inflamed and have lots of blood loss as well too. Anecdotally, maybe we're not seeing quite as much of a response with molidustat in that population. And I bet you if we repeated it, we might see that Darby actually might come out to be more effective. Because I think seeing that 2/3 of those patients responded, I mean, as I've heard you say, like, those are kind of the worst of the worst patients that you were giving the drug to. Am I quoting you wrong there, Kathy?
Yes, there certainly were dialysis patients in there, but the ones that I remember the most that didn't respond were the CKD cats not on dialysis who also had congestive heart failure, and we kept tapping their chest, or they had a UTI. They'd been responding and then they developed a UTI and they stopped responding. We treated the UTI and then they would respond again. I guess I remember the ones that weren't on dialysis, and as far as I know, weren't having GI bleeds. I mean, you can't always tell that with the diagnostics we have available, but.
And I think it's important what Quimby just pointed out too, that general practitioners, and I would argue clients too, aren't super comfortable with Darby, and people like really prefer the idea of giving an oral medication over an injection. And I think that like shouldn't be understated either. That's like a way less scary idea.
To some people, right? Because we have other clients
Yeah.
that can't medicate their cats, and it's so stressful, and they're doing sub-Q on Dancitron because they can't give anything oral. So I think for some people, getting a once a week injection is a lot easier than every day if their cats are unwilling to voluntarily accept the medication. And whether or not GPs are more comfortable, this protocol is so many more visits for the cat. I mean, there's no question that the current protocol of checking them frequently, stopping at 28, stopping for a week, coming back in, restarting, that's a lot more visits for the cat to come in than for how we traditionally dose Darby. So that's the other factor too, is what's the stress level of the cat to have to sign them up for that many more frequent vet visits to monitor their PCV along the way.
Yeah, and I think, a big reason for people not being compliant with ESAs is kind of the doctor, or at least our doctor's office visits that they have to do for an injectable medication. And that's why this class of drugs has been so attractive to human CKD patients. And at the moment, the protocol really kind of is exactly the opposite from that perspective for our patients.
Well, I'll be interested to see what happens with iron, because this drug seems to have other effects to improve iron utilization. And even though that wasn't looked at, as far as I know, in either of the clinical studies, that's something that I think it's going to be interesting to see.
Well, I think it's exciting to have another option and something that's actually being developed and labeled for cats. No way do I want to be dismissive of that. I'm pumped to have this on our arsenal, but wish I could just do what I want with it already.
And I do wish that it were a slightly more powerful drug, but
maybe 10 mg per kg would be significantly more powerful.
Yeah.
Stop telling me what to do, FDA. Well, Joanna, that was awesome. That was really great. Any other comments, questions from the group? We're coming up to the end of the hour. Just want to make sure everyone has an opportunity to speak and share their thoughts, whether that's verbally or with the microphone or with the chat. All right. Well, if we don't have anything else that pops up, we can certainly bring this session to a close. I think someone might have said something. Oh, you're just being applauded, Joanna. That's what it is. Well, great. Excellent presentation. Our next journal club will be in January. So hope everyone has a wonderful holiday season, and we'll see you all in 2024. Have a good one.
Thank you. Bye.
Thanks, Joanna.